The topic is non-academic but pretty relevant, because if you want to be a good academician and a good clinician, then you should certainly know how to do a good case presentation. Most of the times when you do a case presentation, when you're assembling some history and examination findings, you're actually trying to state random facts which are not connected to each other. Number two, be genuine with your answers to teachers. Your improvement gets better when you practice more case presentation. Hello folks, welcome to Physics Wala Med. I'm Dr. Patil. I'm a faculty for internal medicine and I teach the entire spectrum of clinical medicine and internal medicine for NEET PG, INICT and FMGE aspirants on Physics Wala Med. And you guys probably know me through my Reed Harrison series. And I'm back today with an interesting topic. Yes, the topic is non-academic but pretty relevant, because if you want to be a good academician and a good clinician, then you should certainly know how to do a good case presentation. So today we will learn how to do a perfect case presentation. But before that, tell me one thing. If you have to present a case to one of your professors, is it a very soul satisfying experience or it scares the shit out of you? If you feel very apprehensive of presenting a case to your professors, then the 7 to 10 minutes that you are going to spend on this video will definitely make it a better experience the next time you present a case. Okay, so if you want to do a perfect case presentation, see, all of us have this experience, right? Like, I want to present a case. I started with complaints, and then at every stage, at complaints, at history of presenting illness, past history, drug history, family history, general physical examination, systemic examination, my professor kept ranting. He was not happy with whatever that I was saying. A lot of you have this experience, right? Why? Because most of the times when you do a case presentation, when you're assembling some history and examination findings, you're actually trying to state random facts which are not connected to each other. And that's why your teacher is not able to picturize what is going on with the patient. So basically, case presentation is storytelling. So you are literally telling the story of the patient. Only thing is that the story should culminate in the right climax, which is the diagnosis. So you have to tell the story in a way that it leads to climax. If your storytelling is going haywire and it is not leading towards the climax, that is diagnosis, then it makes no sense to the spectator, right? Okay. So how can I ensure that my teachers get happy when I present a case? So I have a 4-point algorithm for a better case presentation next time you do it. The first point is about history. So when you take history and document it, because see, when you're presenting a case, 70% of the time is spent on discussion on the history itself. And sometimes your teachers get so angry that they don't even go to the examination point. Before that, they walk out, right? Why? Because history is where the majority of diagnosis is made. Let me tell you an example. Okay, I have a patient who presented with increased JVP or distension of neck veins. Okay, and on examination, I also noticed that he has hepatomegaly, liver is enlarged, he has ascites, and he has pedal edema. Some of these are complaints, some of these are my examination findings. Okay, so when I put these together, a picture emerges in my mind that okay, this patient has something wrong going on with the right side of the heart. It means he has a right heart disease. Now, if I am a listener, I am an examiner or a teacher who is listening to this case presentation, when you're telling me the symptoms, okay, at least I'm sensing that some problem with the right side of the heart. Now, I would expect you to give me more details. If you tell me from the history that all these symptoms are occurring in a patient with tuberculosis, you added the history of TB. Now, one possibility I can think of is the patient would have developed something called as constrictive pericarditis. The pericardium is not letting the right ventricle fill properly, leading to increased right atrial pressure, and that is leading to raised JVP and all these problems. Before you told me that this is a case of TB, I had a wide spectrum of possibilities of right heart disease. Like I would have thought about tricuspid stenosis, tricuspid regurgitation, pulmonic stenosis, pulmonic regurgitation, cardiac tamponade, right ventricular myocardial infarction, pulmonary hypertension, and heart failure like cor pulmonale, and even left heart failure, eventually leading to right heart failure. These are all my possibilities for someone presenting with these symptoms. But the layers of information that you add from history changes what I think as a priority diagnosis. If you say TB, then constrictive pericarditis becomes a possibility. Okay. Or instead, if you say that patient had raised JVP and this symptom appeared too rapidly, means it is like an acute onset, so it could be right ventricular MI or it could be cardiac tamponade. Or if you tell me that he is a known smoker and he is also, because of smoking, is a known case of COPD, then these symptoms could be because of cor pulmonale. So as a doctor, when I am taking history, I am looking at like from symptoms. See, basically our case history to examination is about taking symptoms, from symptoms, going through history and examination to lead to diagnosis. This is our journey, right? So ultimately I want to diagnose a case, and to diagnose a case I do get clues from history, I do get clues from examination, and put together I reach the diagnosis. But if your history is haphazard, you're just randomly stating information which is not helping me to recognize a pattern of a particular organ involvement or a particular disease, then it makes no sense to me, right? So I won't be happy. So at the level of history, try to identify. See, let the patient tell what is going on with him, but you try to identify what could be wrong with the patient. At your level of understanding, just think, okay, so these now you know these are symptoms of right heart failure, right heart dysfunction, or this patient is saying one side of the body is weak. So then you know, okay, it is something to do with the motor system. A patient is saying he has lost some sensation. Okay, it is something to do with the sensory system. So identify a pattern. And then in the history itself, once you identify a pattern, like let us say I identified that patient has loss of sensations. So it is a sensory system disorder. This is a right heart disorder. If I have cough and fever and shortness of breath, it could be pointing towards a respiratory system disorder, right? So try to identify a pattern or at least a system that is likely to be affected. And at that point itself, think about the possible differential diagnosis or causes you can think of. Like if loss of sensation, it is a sensory system disorder. What are the causes I can think of? I can think of diabetic neuropathy. I can think of lead neuropathy. I can think of some variants of GB syndrome. I can think of a spinal cord lesion affecting the ascending tracts. I can think of the thalamus in the brain being affected, which is all part of sensory system. And now in the history itself, make an attempt to ask leading questions, trying to extract what could be the possible cause. Like sensory system, if I'm thinking about diabetic neuropathy is a possibility. So in that case, I will ask whether patient is a known diabetic or is he on any medications for diabetes. If yes, then this differential diagnosis becomes more likely, right? Then it could be lead neuropathy. So I would ask if there is any potential history of lead exposure. Does you work in an industry where lead use is common? Or are there any other reported cases of lead toxicity in your vicinity because of water contamination or whatever other causes? So we are making an attempt to make the history more, to make the history make more sense to us, right? Then what else I can think of sensory? Then I can also think about spinal cord lesion. So I will ask whether he has any history of trauma to the spine, right? I will also ask if there is any history of back pain. So I'm trying to figure out if I can zero down to something at the level of history, right? So first thing is attempt at the level of history to figure out what are possible causes, and then document relevant history that supports or refutes the possibilities that you're thinking about. Okay, then after that, what else I need to do at the level of history? Your teachers have more experience, so they think of a wide spectrum of differentials and they start asking you questions like, did you ask about this? Like if you say, sir, patient has loss of sensations, I might ask, like, did you ask about anti-tubercular treatment? Because some of the ATD drugs are also known to cause neuropathy, right? And if the patient sitting in front of me is constantly coughing, looks emaciated, so it could be TB. So I might ask this. Now, what will you answer, right? You have not asked this history. So common mistake students do is give some random answer. I've asked and he's not on, or I've asked and he's on. You lose your authenticity. You somehow try to patch up with the situation instead of being authentic, being genuine in giving your answers, right? So number one, at the level of history, attempt to recognize the pattern. Attempt to recognize pattern, like at least try to identify which organ likely is affected, and then think about the possible differential diagnosis, and then to rule in or rule out, ask extra information from the patient, right, using the leading questions. Number two, be genuine with your answers to teachers, because teachers are experienced. They will catch you. You say something and I know when you're lying, so I will definitely catch you and I'll ask the patient, and the patient will tell the truth and you're caught. There is now serious mistrust between you and your teacher. Next time when you're presenting the case again, he won't trust you even if you are genuine. So be genuine from the very first case presentation. Okay. Then third, at the level of history again, document anything that you felt is relevant. Don't think of like, I'll keep it in mind but I'll not write and then I'll be able to present. No, you will forget. So you may not be able to present, right? So attempt to recognize a pattern from the history based on the symptoms and the history features. Be genuine to your teachers whenever they ask some question. If you have asked it to the patient, tell I've asked. If you're not asked, say, sir, I'm sorry, sir, I did not ask that. If he says, why didn't you ask? Then you can say, sir, it did not flash to me. Right? Or if you feel that it was not relevant to ask, then you can say, sir, I felt it is not relevant to ask. But the best and safest answer is, sir, it didn't strike to me. Okay. First key point was history, right? Second point, this is very, very important. Differential diagnosis at every stage. What do I mean by that? So once I walk up to the patient and ask him what's wrong with you, he starts telling me the complaints. So from complaints to history of presenting illness to all other components of history to examination, at every stage I have to stop and think about the possible differential diagnosis. Because once I know, like, our journey of symptom to diagnosis starts with symptoms, right? Or what you call as presenting complaints. Symptoms or presenting complaints. Then we go to HOPI. From HOPI, history of presenting illness, to other history, right? Like past history, drug history. Then we eventually go to examination, the general physical examination, and then relevant systemic examination. Finally, we come to diagnosis. So at every stage, you have to stop and think about differential diagnosis. So at the end of symptoms itself, stop and think about differential diagnosis. Like, what are the possible differentials for this particular symptom? So if I have cough and fever and dyspnea, what are the possible differential diagnoses? We would think of infections. Cough, fever, shortness of breath, infection. Which system it is localizing to? It is localizing to respiratory system. So respiratory infections. Again, what are possibilities? Upper respiratory tract infection, lower respiratory tract infection, right? So if cough, fever, shortness of breath are complaints, it is more pointing towards lower respiratory tract infection. Upper respiratory is less likely to cause shortness of breath. So now I'm going in favor of some possibilities and going slightly away from some possibilities. So as I go to the next stage, I will put more, I will try to extract information which consolidates and narrows down my differential diagnosis further. Like if I had said cough, fever and shortness of breath, that too severe, then you're thinking about lower respiratory tract infection, right? So now when I come to HOPI, I would like to identify the possible causes for lower respiratory tract infection in this patient. So I will ask, was there any contact with another person with the similar symptoms? Because if there are many such reported cases, it could be part of a viral or any other infectious epidemic. Or I would also ask him whether he has got, like, if the duration is not acute, subacute or chronic, whether he has got weight loss, whether he has hemoptysis. These may be pointing towards the tuberculosis or maybe pointing towards the lung cancer. So I will ask relevant questions in HOPI to narrow down my differential diagnosis further. But if I just go on randomly, okay, separately I will record the presenting complaint, separately I will record HOPI, then it makes no sense. So once I have some differential diagnosis, HOPI, I'll try to get information to narrow them down. At the end of history of presenting illness, I might have narrowed down some differential diagnosis, like some may be ruled out and some may be more clear now. Like a patient with cough, fever, shortness of breath of only 3 days duration. Okay. And then history of travel to some other country where there are plenty of reported cases of swine flu. So my differential diagnosis is narrowing down. Now I'm almost thinking that this is a case of swine flu, right? So differential diagnosis further narrowed down. The other history may also help me narrow down the differential diagnosis. If there is family history or if there is any drug history, so they may be contributing causes, right? And then on examination, I will try to confirm, like again at the end of complete history. So here I will rethink about what are my differential diagnoses and whether I'm leaning in favor of something or leaning away from something. Again at the end of other history, I will look at the differential diagnosis. So at this point of time, I might have 10 possibilities. By the time I complete the history, I might have 5 differentials as possibilities, right? And then when I get into examination, now I have some targets, like, okay, these are 5 possibilities. So examination, I should try to figure out which one of them is likely. To give you an example, we just took an example, right? Patient with fever, shortness of breath and cough. So now this could be a possibility of a pneumonia, viral, bacterial, right? Tubercular, fungal, or could be ARDS. Now from history I have narrowed down, because I just told you that travel to some country where swine flu is being reported. So I have narrowed it down to viral. Now in examination, how will I confirm? Generally viral pneumonia does not cause lobar pneumonia. It's usually bacterial pneumonia which can present as lobar. Viral pneumonia presents as bronchopneumonia. So if on examination I get bronchial breath sounds from only one lobe, then it is more likely a lobar pneumonia. So then, so far whatever differential diagnosis I had a priority diagnosis seems to be less likely. I should think of other differentials as more likely. But if I get abnormal breath sounds from both the lungs, diffuse, not affecting only one lobe, right? In that case, my diagnosis of viral pneumonia becomes more likely, right? Already I had that as my priority differential. Examination has given me more conclusive evidence to think of this as viral pneumonia. So now my diagnosis will be, at the end of examination, my differential diagnosis has clearly shown emergence of one as a possible most likely diagnosis and other are possible diagnosis, right? So now when I present diagnosis, I will say, sir, this is the most likely diagnosis. These are my differentials for this particular diagnosis. So if I don't think of differential diagnosis at every stage, I just randomly progress from symptom to diagnosis, it becomes a haphazard case, right? So keep it methodical. So at every stage of your history taking to examination, think about differentials, and in the next stage, think about how you can differentiate between these differential diagnoses that you had in mind. Okay. Then third one is eliminate traps and traps. What do I mean by eliminate traps and traps? So when you have finally completed the examination also, so now your case sheet is ready. And in this case sheet, you have symptoms, HOPI and rest of the history, general physical examination and systemic examination. And now when you look back, you might notice that you have asked some questions which are not relevant. Means this case seems to be looking at a totally different picture, like this now emerges as a pneumonia. But in the beginning, you have asked a lot of questions which are not even relevant to respiratory system, just because in your case examination book there are some random questions mentioned, you have asked them, but now they make no sense. Should I keep it? Well, no. Keep your history concise. Only what information is relevant is required. You don't have to have 100 number of questions asked to patients and their answers mentioned there, and then that becomes your case sheet. No, it should be concise. So whatever crap you have included in your history sheet, strike it down. You don't have to keep it there. And then traps. What are traps? Okay, so now my case sheet is complete, and unnecessary questions I have taken down, unnecessary information I've taken down. But then I have asked some questions which seem relevant, but if the teacher asks me, why did you ask that? I don't know what should I answer. So such things, for a safe case presentation, don't keep it in your case sheet. Later after this, like, okay, it's a known case of TB and I'm supposed to ask whether patient has got weight loss or not, and I really don't know why patient should get weight loss in tuberculosis, and what will I answer if teacher asks why he is getting weight loss? He had asked in the last class also and I was not able to answer. Today also he will ask, I will not able to answer. He will get pissed off and he will walk off. So should I keep this point? Better don't keep that point. But as a student, you should know that, okay, TB patients do have weight loss and I need to figure out why do they have weight loss. So I will, after the class, go and read about it, why weight loss occurs in tuberculosis. But till that time, for my mental peace, for the safety, and also to ensure that the case presentation goes on smooth, I will vomit this point from my case presentation, right? Because these are like traps. And you, being a student of your particular teacher for a long period of time, you know their behaviors. So if you feel like, okay, if I utter something on this, they're going to jump on and then the whole case discussion deviates to something else, and I really don't know anything about that topic that the teacher is likely to digress into. In that case, I stop including that in my case presentation, right? So that is the third part. Eliminate the traps and traps. And then the fourth part, practice. The more cases you present, you see, perfection is never achieved in one day. Perfection is achieved by repeating the same damn boring thing again and again. Now, despite all the steps, like you're improving on history taking, you're now able to recognize, this is respiratory system disorder, this is CVS disease, this is CNS disease. Within the CNS, this is motor system disorder, this is sensory system disorder, this is higher mental function disorder. Within the respiratory system, this is upper respiratory tract disorder, this is lower respiratory tract disorder. Within the lower respiratory tract disorder, this appears to be airway disorder, this appears to be a parenchymal disorder. You're able to recognize these patterns from symptoms and history. Good, right? And then when you look at symptoms, your mind is now able to pick up, like, these are the possible causes. And then in the history of presenting illness, you're able to put an effort to identify what is a more likely cause, right? You're able to get some points to support some diagnosis. You're able to get some, extract some points from the history to refute some diagnosis. So you're on the right track, right? To keep getting better at it, think about differential diagnosis at every stage of the encounter with the patient, from symptoms till the examination. And then, just for the safety of yourself during the case presentation, so that you don't get, like, literally looked down upon by your teachers for not knowing something, make sure you don't include craps in your history. And if you know that something is a trap for that particular teacher, don't include that also in your case presentation, right? And the last one, despite when you are making improvement, your improvement gets better when you practice more case presentation. And when I say practice, you don't have to always present to your professors, because you get 2 months in your second prop and another 2 months in your final prop. So maybe 4 months of posting. And in that 4 month of posting, you might get around like 8 or 9 chances to present a case. That's not enough. So then what should I do? Present the cases to your seniors, like that could be interns, that could be residents like PG students, or that could be senior residents, or even your colleagues. Now, when you're presenting to your batchmates, you may not get insights, but you do get the confidence to stand and talk about a patient's symptom all the way till the diagnosis. But when you present to a senior resident or a PG student, you will definitely get insights. Regardless of whether you're likely to get insights or not, keep presenting. Practice makes the man perfect, and the women also, right? So these are my 4 key tips for you to ensure you have the best case presentation few months down the line. So that's it from me today. I'll see you with such interesting topics where on the Physics Wala Minute. Till then, have a good time.